Welcome to our podcast, Multiple Myeloma Morning Commute, Giving the Snowball a Chance. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Oncopeptides and Sanofi Genzyme. In this episode, Dr. Ravi Vij and Dr. Thomas Martin go into a rapid-fire round discussion of new and emerging therapies for the treatment of triple-class refractory multiple myeloma. Information about the faculty and disclosures can be found at morningcommutepodcast.com/multiple myeloma 5. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Vij is a professor of medicine in the Division of Medical Oncology at the Washington University School of Medicine in St. Louis. Dr. Martin is a professor of medicine in the Division of Hematology Oncology at the University of California, San Francisco. I am Candace Hoffman, managing editor of Morning Commute. Dr. Vij will begin our discussion.
Hello, my name is Ravi Vij. I'm a professor of medicine at Washington University School of Medicine. And today I have with me Dr. Thomas Martin from the University of California in San Francisco. Welcome, Tom.
Hi, Ravi. Thanks for having me.
It's a pleasure. So we are today going to talk about the progress in the treatment of triple-class refractory multiple myeloma. And we're going to talk about how some newly approved regimens and some emerging ones fit into the treatment paradigm. So this is going to be rapid fire, Tom. I'm going to just throw the drug at you and you tell me where you see it in triple-class refractory patients. Let's get started. You ready, Tom?
I think I'm ready.
Okay, selinexor.
Okay, in triple-class refractory, selinexor was essentially approved for use in combination with dexamethasone as a twice-weekly oral regimen. And this actually showed a response rate of selinexor plus dex of about 25%. In triple-class refractory patients. This is definitely an agent that I use in patients who I don't have anything left, basically in the armamentarium to treat them. There are side effects, and we have to watch closely about them. Mostly people have nausea, fatigue, low sodiums, and low blood counts. And so we really need to watch them closely and ameliorate these side effects to make them continue on the therapeutic.
Belantamab.
So belantamab is a Bcma-targeted ADC. So it binds to the myeloma cell through Bcma, gets taken up into the cell, and then releases its toxin, MMAF, into the cell. And this actually also in the triple-class refractory patients has shown a response rate very respectable in the 30 to 33% range. This agent, interestingly, has been associated with some keratopathy or corneal toxicity. In about 3/4 of the patients when they see an ophthalmologist, and you have to see the ophthalmologist before the first dose and then before every subsequent dose, will have some toxicity to the surface of the cornea, and that's called keratopathy. In about half of those patients, you do have to either dose reduce or you have to stop the administration of the drug and give them time to heal. But this has proven to be a very effective drug for me, and I've used it in a number of patients.
Melflufen.
These are all very interesting classes of drugs and novel classes of drugs. So melflufen is an alkylator-based therapy that actually has a lipophilic moiety attached to it. The lipophilic moiety gets it into cells. The melphalan component is what is toxic to the cells, just like a standard chemotherapy. In cancer cells, like myeloma cells, they actually have an increase of an enzyme called an aminopeptidase inside, and they'll cleave off that lipophilic peptide. And so the drug gets in, the lipophilic peptide gets cut off, and the drug is trapped inside the cell. And this one also shows a response rate in triple-class refractory of about 30%. The nice thing is it's given every 4 weeks by IV administration over 30 minutes. Right now, it does have to be given through a central line, but they're testing it in peripheral IVs. And it's given together with dex, weekly dex. And it just was approved 3 weeks ago, and we're excited to get going on standard of care therapy here at UCSF with this molecule.
Something that you've been intimately involved with, isatuximab.
So isatuximab is a CD38 antibody that is a little bit behind daratumumab in its development, but it is as good as daratumumab as an anti-CD38 antibody. And it actually showed benefit in combination with pomalidomide and dexamethasone, the ICARIA study. In patients who had received at least 2 prior lines of therapy, they showed a response rate that was close to 60% and a PFS that was almost a year. It was 11.5 months. In this combination of isatuximab plus pomalidomide and dexamethasone, very well tolerated. The other place where it likely will get approved soon is in combination in 1 to 3 prior line of therapy with carfilzomib. And so isatuximab plus carfilzomib and dexamethasone was tested in the Bcma study, and that study is in follow-up. Basically, I project that the progression-free survival in that study is going to be probably more than 30 months. It's going to be one of the highest PFS values that we've seen in a relapse refractory trial. So that combination I'm very excited about.
Where do you see new drugs like CAR T cells and bispecifics to BCMA fitting in?
Those are, drugs that hopefully we're going to see, in terms of CAR Ts in the next few months, and in the bispecifics in the next year or year and a half, we'll hopefully have our first approvals. Now, the CAR Ts are not off-the-shelf products, right? Those actually have to have T cells harvested for the patients. They have to be sent to the company. The CARs have to be made. Patients get bridging chemotherapy, and they have to be given back. So it's a little bit more complex, and it has to be done at a treatment center. And there's about 70 treatment centers in the U.S. But those drugs have the power of what my colleagues say the one-and-done phenomenon. You get a CAR T-cell therapy, and then hopefully you get a period of time, maybe a year or longer, where you don't need any other myeloma therapy. And that's really a big quality of life advantage for a lot of the patients. In terms of the bispecifics, they're just as potent, showing really exciting overall response rates, 70 to 80%. And we really don't know how durable these are just yet, because most of the studies presented haven't been able to show durability at the current time. But we suspect that they are going to be durable, and the PFS is actually going to be quite good. It might actually approach the same amount as CARs, or may even be better. So very exciting times.
So it seems like BCMA is a hot area, but we're already looking beyond BCMA. So GPRC5D as a target.
Yeah, so there's other cell surface targets on myeloma cells. Now, we know BCMA is a really good one because it's limited to basically plasma cells and cells of the lymphoid component. Now, there are these other markers like GPRC are highly expressed on malignant plasma cells. They're also in some other tissues, including skin, and so there have been some toxicities and rashes on people receiving these therapeutics. But we have a CAR T-cell therapy that's in clinical trials, and we also have a bispecific T-cell engager. Now, the one that was presented recently at our meetings at ASH in 2020 by Dr. Ajit was talquetamab. Now, talquetamab has been tested in more than 100 patients, and at the current time, they're actually testing it by subcutaneous injection. And this drug is looking like it's going to give a response rate, again, in the more than 50, potentially more than 60% response range, and amazing. And so we'll have to see. These drugs are also associated with other toxicities like CRS, cytokine release syndrome, and some neurotoxicity. So we'll have to see how, over time, when we get to the right dose, how much skin toxicity we're seeing, how much CRS we're seeing, and how much neurotoxicity we're seeing. But these drugs are going to move forward, and they're going to be important parts for triple-class refractory myeloma, and then eventually for earlier forms of myeloma.
FcRH5, Tom.
Yeah, so there's another receptor, FcRH5, that's actually being tested. This is a drug that was presented at ASH. It was called Savostamab from Genentech. It was actually presented by Adam Cohen at our meetings. And as you know, this also, as given as a subcutaneous injection, showed very encouraging response rates. Response rates, again, in the 50 to 60% range. This is an activating antibody, again, binds to the myeloma cell through FcRH5, and then it activates CD3. So it is associated with CRS, seen maybe in 3/4 of the patients as reported at ASH, and about 20 to 25% to 30% of patients had some neurotoxicity. So, these are side effects that occur with these activating agents. And again, once we get to the right dose and more patients treated, we'll really be able to hone into what the actual percentages of these toxicities are. And at the current time, they've all been manageable. And these will be important components for triple-class refractory and also for earlier stages of myeloma.
Will they work for BCMA refractory?
So that's a great question. And so one of the things that I think is important as we move forward is, we've tested it in triple-class refractory. Patients that were refractory to immunomodulatory drugs, refractory to proteasome inhibitors, and refractory to CD38 antibodies. But now we're using, drugs that target BCMA, right? And so we're now going to have this 4-class refractory patients. We have anecdotal reports that patients who have received a BCMA-targeted therapeutic, whether they've received a CAR, or they've received a BCMA-targeted bispecific or an ADC, that they have responded to other therapies, including other BCMA-targeted therapies. So some patients got a CAR and then responded to a BiTE, or they got a CAR and then responded to a BCMA ADC. And in these novel drugs, like the GPRC5D and also the FCRH5, they're also going to test whether or not, patients receiving other therapeutics, including BCMA-targeted therapeutics, will respond to these therapeutics, but undoubtedly they will.
What about Venetoclax?
Oh, Venetoclax. I think Venetoclax has kind of been lost in all the shuffle and all the excitement of all the BCMA-directed therapies. But as you know, Venetoclax is a drug that targets BCL2. And we have a subset of patients with myeloma that have translocation 11-14 that have upregulation of the BCL2 pathway. And these patients have shown to respond in the relapse refractory setting to Venetoclax-based therapy. We had a large phase 3 trial called the Bellini trial that tested Venetoclax with bortezomib and dexamethasone. And it was in all comers, 1 to 3 prior lines of therapy. And the study was closed due to toxicity, increased infections, increased cardiac toxicity, and increased deaths in the triplet drug arm. Now, when we looked at the sub-fraction of patients with the 11 and 14 in translocation, in fact, those patients did very well, had one of the lowest hazard ratios of any trial we've ever done, and had a response rate of over 90%. And so this drug will move forward. It will eventually get approved, but it's going to be approved in the small fraction of patients that have the 11-14 translocation.
Last, CELMoDs.
Yeah, so the next generation drugs from the immunomodulatory class are these CELMoDs. And these are drugs that actually do bind to cereblon and work through cereblon and decrease the effects of Ikaros and Aiolos. And these CELMoDs actually work in patients who are refractory to lenalidomide and are refractory to pomalidomide. These are more potent binders to cereblon. And these drugs in my mind, have a very exciting future. And 10 years from now, we're not going to be using lenalidomide and pomalidomide. We're going to be using the next generation CELMoDs and other drugs that target cereblon, et cetera.
That was quite the overview, Tom. I must say you're an encyclopedia of knowledge here. So it seems like we have a lot going on in triple-class refractory myeloma, a lot of options that have come about commercially, a lot more to come. And it is that the pipeline of myeloma never seems to run dry. Do you agree, Tom?
Oh, totally. This is so much fun being a myeloma doc right now, and I have so much fun talking to the patients about all the potentials we have in the next 5 to 10 years.
I agree. I think that it's an exciting time to be a myelomatologist, and I think we look forward to using these drugs in clinical trials in commercial application in the years to come. So once again, I want to thank Dr. Thomas Martin for that wonderful overview. Thank you very much, Tom.
Thank you, Ravi. Have a nice day.
Thank you.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/multiple myeloma 5. For all the episodes in the 6-part series, please visit morningcommutepodcast.com/multiple myeloma. Thank you for joining us today.